Goals. By the end of day one, you will be able to describe what practice without pressure is and is not. We're going to take you through the historical perspective on people with disabilities, especially what we call IDD, intellectual or developmental disability. We want you to be able to understand and describe the medical and social models of care. There are differences, and you will see them today. One of the main tenets of practice without pressure is no restraint. We feel very strongly about that, and you will hear the story as to why very soon. But we want you to understand how restraints actually impact high-quality care. I'm bringing someone in that I've talked about with some of you before, but most people probably don't understand the work of Sylvan Tompkins. He is a psychologist, happens to be from the Philadelphia area, which is kind of where I found out about him. But Tompkins' work is kind of groundbreaking. You're going to see how we can change negative cycles to positive cycles, and you're going to see what that means. Objectives. How do you recognize trauma? We hear it, we talk about it all the time. You're going to hear some things about trauma-informed care. How do you recognize it? Culturally responsive care. We're going to touch on that as well. We have to understand that there is more than one culture in our world, and in our big world, our society, and in our little worlds every day. So culturally responsive care is very important. We're going to learn how to set expectations. We're going to talk about disability categories, and I want to make a disclaimer here. Disabilities, especially intellectual disabilities, are still thought of in this world today, in our world here in the United States, but also everywhere else, it seems, from a category perspective. What we're going to show you is the categories in the diagnostic manual of the American Psychiatric Association. You're going to see that. It's very clinical. We're also going to present information on disabilities from the people and their family members and caregivers themselves, okay? So you're going to get disability from both perspectives. And we're going to talk about how access to care is impacted for people with disabilities, just the actual access to care itself. So today is going to be background, theory, that kind of stuff, okay? That smiling face right there. Some of you know him, some of you do not. That is my amazing son, Mark. He's 34 years old. As I said before, he's a fan of all things Philadelphia sports. When the Eagles play, sorry, any Dallas fans or Houston fans or anybody else, we are dyed-in-the-wool Flyers fans and Eagles fans. He gets so excited. Mark curses like a trooper, screams and yells at them, and then says, I can't wait for the next game. Mark was born 34 years ago with Down syndrome and major heart issues. This is sometimes a fairly emotional part of the story that I tell. He was in the hospital for a month with his cardiac issues and gut issues and eye issues and all that. I know we have at least one mom of somebody else with disabilities here, Down syndrome, who understands that from a mom perspective. It's tough. It's tough. But you know what? It's part of your life. We get through it. Mark had his first open heart surgery at 6 months, his second one at 6 years because of, and Talia, I know that you'll understand this, he had endocarditis at 4.5, which is an infection in the lining of his heart. He had major damage to his mitral valve. So anyway, that's the medical part of it. But by 6, he'd had 2 open heart surgeries, and he'd had a lot of stuff. And he got very afraid of anything in his personal space, anything. So, you know, I'm not small. Guess who had to be the holder-downer, the restrainer? That was me, mostly. His dad secondary, but that was mostly me. By the time he was 11 and a half or 12, he had to have allergy testing done. It was a nightmare, all the little picks down your back you have to go through. And within a half an hour, we had 3 done, okay, 3. And I finally said, stop. I was sweating like a pig. He was sweating. The tech was sweating. Because I yelled, I screamed, I begged, I pleaded, I did everything, couldn't get it to go. And I said, stop, just stop. We have to stop this. So she left, and the doc came back in with a prescription pad in his hand, and he said, Mrs. Jastrzebski, this can be done by a blood test. And he said, good luck. He wasn't being flip or mean, he just had no other options for us. It's either restraint or you have to go find it somewhere else. So I looked at my beautiful son on the way home with the blood vessels burst in his face. This was 24 years ago, mind you. And I said, we'll never do this to you again. I will make sure that we will never do this to you again. And I meant it, even if it was life-saving. Now imagine that, even if it was life-saving. So my background was as a physician's assistant and a computer analyst, so I put everything to work and realized he was afraid of anything in his personal space. He would get like this, talk about a trauma response, when he saw anything that had to do with needles or haircuts or getting his nails done, okay, or anything. So I figured that if I could do little pieces at a time with him. Rachel, she was 5 at the time. She was his model for this blood draw. 5 years old, she was his model. So she'd been involved in this for a long time. We did little pieces. I worked with Rachel, I worked with Mark. I worked with Rachel, I worked with Mark. At one point, his dad came in, Sandy, I'm gonna use you as a, you don't have to do anything. His dad came in to the room that we were practicing, and behind him, and he went like this to Mark, and Mark went, because it was his body had reacted so that he thought his dad was going to hold him down again. Well, I said, now I really get it. I went and talked to the phlebotomists that were going to work with us, and I said, you can't do it your old way. What do you mean? And I kept talking to somebody, talking to each phlebotomist until I found one that said, well, tell me, what are we going to do? And I said, we're going to do it like we practiced. And I need you to give me the actual equipment. Give me a tourniquet and a blood kit. She said, I'll give you everything but the needle. Okay, got to figure out a needle. I went home and opened up a paper clip, and I think I still have it in my mementos. If you open up a paper clip, it looks like a needle. And if you poke somebody with it, it hurts like a needle. I mean, you can simulate the pain of a little blood draw. So I was doing these little 5-minute sessions with Mark over 2 weeks with Rachel as his model. She would do it, he would do it. She would do it, he would do it. Got to the part where we stuck him with the pseudo needle, and he went, Mommy, tickles. I was like, okay. So I kept that same phlebotomist information, and it was time to go get the blood draw done. We went in, and I kept saying to him, Mark, just like we practiced, and I said to the phlebotomist, just like we practiced, there will be no restraint. But I wasn't confrontational. I just was like, we're not going to restrain him. Okay. She was on board. So you figure I was on board as a caregiver, he was on board as the individual, and the phlebotomist as the caregiver was on board. Okay, she was taking my lead. We went in, he sat down, just like we practiced. She stuck the needle in his arm and he went, Mommy, tickles. Practice, procedure, Mommy, tickles. He got his blood drawn that day, like, I don't know how many vials, I don't have any memory of that. He walked around with that Band-Aid or whatever he was allowed on him, going out to everybody in the waiting room, did it, instead of blood vessels bursting in his face. Did it. Ever since then, so we went from there to dentistry. He hadn't had a dental appointment for many years because of the same thing, did the same thing. Talk to the dentist. Oh, I don't know. I think we might have to restrain him. No, we're not going to do that. We really need not to do that. He went through it like a champ, did the same things. Rachel was my model again, or her sister Sarah, who's not here. And his story went from someone who was developing huge trauma response to actually now Mark works with other people, as some of the folks in this room can attest, to help them learn how to have procedures done. He's gone in the OR with people. He's had more heart surgeries. It has been an amazing transformation. If we would have kept status quo, probably the whole first row here, plus a couple in the back, would have had to hold Mark for his work that he has done. Think about that. I want to share a little story with you. It was important that I told you it was 20-some years ago. And we're going to have, during our caregiver sessions, we're going to have Becky actually share her experiences with Sam, because Becky's son Sam and her daughter Luna both have Down syndrome, and they went through PWP. But I want to share a story with you that Rachel found out this weekend at a conference. A mom came up to her with a child with Down syndrome with pictures of the child being restrained for dentistry, and blood vessels were bursting in that little boy's face. It's still happening, folks, still happening. That is why what we are doing is so, so important. Practice without pressure introduction. Person-centered approach. You're going to hear that more and more often. Person-centered, holistic. We want folks to be able to access healthcare that they've previously avoided. I'll be talking to you guys not just from a professional, but also from a family member perspective, caregiver perspective. We avoid care. We do. Or we get like this when we know we have to go, if we know there's going to be any restraint or coercion or even sedation. We avoid care. You heard me say during telling you Mark's story, took me years to get back to the dentist, years, okay? Accessing healthcare procedures and medical, dental, and personal care. You're going to see us saying healthcare throughout this, but it's medical, dental, and personal care, so we use those interchangeably, which I know they're not. But practice without pressure helps the individual gain skills and capacity to complete their care, okay? Skills and capacity. You don't hear that often out in the world about people with, especially intellectual disabilities. We should. People with intellectual disabilities. So we want them to gain skills. The capacity means to grow bigger, to be able to contain what you do. So we want people to be able to get their skills, but also to be able to grow bigger in themselves. Okay, that's real important. We also work with caregivers and professionals, and that's one of the things that makes Practice Without Pressure different. Working with caregivers and professionals that work with people with disabilities. You don't see that very often, okay? So we bring everybody together, and we're going to show you kind of how that works in a bit. Let's talk for a minute about the challenges of accessing high-quality care. We say child, but it's also adult. So many providers are uneducated in how to work with people with disabilities, or if they should work with people with disabilities, they're afraid. There was a study done by the Surgeon General back in 2009 that showed an overwhelming number of providers of care don't get any kind of education at all on working with people with disabilities, especially intellectual disabilities. So there's a lot of challenges to that. There's physical challenges. You know, if despite having the Americans with Disabilities Act, which says you have to provide accessible entrances and things, there's a lot of places that still don't. You know, the places like the MAC are unusual. Even getting people with disabilities to the doctors or to the dentists. Studies are done that show that a lot of folks with low income have more of the individuals with disabilities, and it's harder for them financially to get people where they need to be, to make all the commitments that they have. So that's another barrier. People are frustrated with focus on the procedure, one and done. You got to come in, it's compliance, compliance, compliance. And I want to put a disclaimer in here. That's what our professionals have been taught. That's what parents and caregivers have been taught. That you have to get one and done, one and done. So it's frustrating for everybody though. PWP works to shift the focus from the procedure to the person, okay? That is a huge paradigm shift, and it's hard for everyone often. Professionals, it's very hard. They're used to having to or being able to run everything. And, Mariah, I'm going to tell you what you need to do right here, and you comply, right? That's part of what happens. But that's what they've been taught. Caregivers have been taught they have to make their child or their person that they're supporting compliant. And the individuals, they're just kind of like, I don't know what to do. But that's a big part of the issue. What Practice Without Pressure aims to do, again, is to reduce sedation and eliminate restraint. And we'll talk a little bit more about this later, but sedation, I'm okay with it if it's the last resort, but it's also how it's administered. Oftentimes you'll see 4 and 5 people holding an individual down to give them sedation. Practice Without Pressure works towards that not being the case, because that's still the restraint. It still causes trauma to everyone involved. Increase in the human rights, dignity, and respect of everyone with disabilities accessing necessary health care. You're going to hear from those folks themselves in just a few minutes. Now let's get into the historical perspective of disabilities. Basic rights, denied basic rights. I'm sure, has everybody here heard about the institutions from the past? That continued up until very recent past, if you were to really think about it. Let's talk about improper regulation of institutions. We can talk about unsanitary care, lack of resources, lack of access to health care, neglect and abuse. They also had no family interactions at all. One of my worst nightmares when Mark was born and growing was that he would end up shuttered away in an institution. Okay? That was a nightmare that I had, regular recurring nightmare. I worked with individuals whose families were told you must put them away when they were 2, 3, 4, 5 years old. Okay, so that was historically, and listen, they were told and they complied. Families were told they should put them away and they complied for the most part. Yes, some families couldn't handle it, and that's a different story. That's not what we're talking about here. I have a cousin who is 78 years old now. She has CP and, cerebral palsy and intellectual disability. In the 50s in Michigan, her parents, my Aunt Jean and Uncle Jack, were part of the ARC movement, and we'll talk about those movements in a little bit, to bring people out of institutions. Karen was never institutionalized as a child, which was unusual back then. So, getting down to the health care of folks in institutions, it was really a warehouse. Picture that. I couldn't make myself put pictures up here, but if you can imagine people sitting in rows on the toilets being tied to toilets, that's how things were in those institutions. I personally worked with folks at an institution that still had the giant shower rooms with hoses that they used to put people up against the wall and hose them down, just like they do in prisons. These were people with Down syndrome, with Fragile X, with autism, okay? This is how they were treated up until the 70s, if not further, okay? So from the 70s to now, we've come a long way, but I'll tell you what, we got a long way to go. People with disabilities are now present in our communities. I will share with you when Mark was born April 5th, 1989, he was due April 1st. There was no representation of anyone with Down syndrome on TV, just wasn't. But in September of that year, the show Life Goes On came on. Starred Chris Burke, an actor with Down syndrome. It was unheard of. His dad and I sat and watched the show with Mark in our arms, just bawling our eyes out, because it was just a family. They showed him, he had whatever. That was the first time ever that I ever saw, and now people with Down syndrome are everywhere, people with disabilities are everywhere. You see them represented everywhere. Practice Without Pressure does not work with these parts of people. We don't work with the diagnosis. And people look at me like I'm crazy when I say diagnosis doesn't matter to PWP. It really doesn't, because we work with the human being under the diagnosis. Focusing on the individual, there's underpinnings to PWP. The requirement of a shift from the medical model to a social model is very difficult, not just for professionals, but also for caregivers and the individuals themselves. Because when your child is born with a disability, they're born with these disabilities. They're called developmental disabilities because they were before age 21. Some people have intellectual disabilities that come across by like a traumatic brain injury, or they might fall into a pond and lose oxygen for an hour and come up with intellectual disabilities. We've learned from when they're teeny tiny and our first diagnosis that they're looked at as medical models. So we as caregivers or family members kind of take that on as well. Okay, we look at the pieces and look at the parts. And I remember a father telling me one time when Mark was just tiny, Deb, don't fall into the trap of becoming just his therapist or just treating parts of him. Be his mom. Be the person that he needs you to be, his mom. And that has stuck with me even now. Not that I was always successful at it, but it's something to think about, okay? So if we as family members and caregivers and even the individuals have trouble with that, imagine the difficulty that providers and clinicians and professionals have. Professionals have a profound impact, but so do families, caregivers, and teachers. Think about that. Teachers are with our folks when they're young for hours and hours a day. So they have a profound impact on the individuals. When we say here at PWP, we want you to focus on the individual, not the procedure. You think, well, we are focusing on the individual, but we're really not. What we focus on is what we want to do for them or do to them. That's not focusing on the individual. That's focusing on the act, okay? You're gonna hear me say over the next 2 weeks a lot, work with the individual, the procedure will follow, okay? That is a whole, like your brain goes, work with the individual, the procedure will follow. That takes trust. That takes trust back and forth with both sides or all sides. And it's difficult. People with disabilities are not thought of as people often. They're those parts. A person-centered approach, obviously that's a different thing than the medical model. Something that's so different is to communicate directly with the individual with disabilities. We are seeing that happen more and more, but a lot of times you may get from a caregiver perspective, oh, Johnny doesn't talk, they're nonverbal, he doesn't understand you anyway. That's okay. I'm still gonna talk to Johnny. Mariah, you don't speak, but I'm gonna talk to you, okay? I'm gonna make a connection with you and me right now. It's okay. I love that smile on your face, okay? She and I just made a connection. She was a little nervous, but we made a connection already because I spoke directly to her. Remove preconceived notions of expected norms. In the world of PWP, because we're talking about access to healthcare, the expected norm is that you come in, you go through the procedure, and you're done, you leave. That's expected, and that's okay. But when you add a disability to the mix and you add a caregiver to the mix, oh my God, all of a sudden everything just goes kerflooey. My son Mark has a disability. He does have a processing delay, okay? Because he has a processing delay, he needs a different way. He needs to practice things that other people learn just like that, you know? I learned how to go to the doctor. I learned the protocols. I learned the norms. With Mark, I had to help him learn those things because it was too much. We were forcing too much on him. So the norms are okay. It's not that they're bad things. We just have to help the shift to say, okay, Mark doesn't go with these norms. Let's help him to work through some of that and change the norms a little bit. You're going to hear this so much from me. You're going to think of it in your sleep. You're going to find songs to it. You're going to dance to it down the street. Alleviate the pressure on the individual. Alleviate the pressure on the individual. How in the world do you focus on the individual but alleviate the pressure? It is magic. It is magic, and I'm going to show you how to do it later. But seriously, there are ways that you can do that. Like, I'm gonna focus on Mariah. This is about Mariah right now, okay? I'm not gonna put pressure on you, Mariah. We're gonna work with Sandy, or I'm gonna work with Daisy a little bit. Taking the pressure off of her while still having the focus on her, okay? That's what this is about, and it can be done. Okay, building positive relationships. Just for a minute, I want to talk to you about something. Building a positive relationship does not necessarily mean you have to see someone 20 times. It really doesn't. You and I should be able to talk for a few minutes and start a positive relationship, okay? It doesn't necessarily mean that we're going to be best friends for 25 years. We might be, because we might find that we like that. But building a positive relationship can be done in a short time, okay? A deeper relationship takes more time, but a positive relationship can be done really quickly, okay? If you have the right approach, you have the right connection, you set the right expectations. We're going to work through all this. You guys are going to see some of this. So I want you to understand one of the issues sometimes with relationship building in the medical, dental, personal care world is I don't have the time. It's not how much time you have, it's what you do with your time, how you approach your things with your time, okay? And I want you guys, if you think of issues or problems with anything I'm talking about, I want you to write them down and make sure we go over them by the end of class, okay? Just know that I want to make sure that we approach this very strongly. Okay, change the perspective. We want to change the perspective. There's a talk out there, and I didn't use it, changing this perspective from what's the difference between a dandelion and a daffodil? They both have yellow flowers, and they have green stems and some cool leaves. Last century, the dandelion was thought of as a flower too. Perspective changed, it started growing in lawns and people didn't like it. Our kids think dandelions are flowers. It's just when they hear, oh, they're not flowers, they're weeds, they're weeds, they're weeds, they sort of lose bringing them to mom or dad as a present, you know. They're still as beautiful as a daffodil. So what we're doing is changing the perspective on people with disabilities and how they approach. We're also changing the perspective for them. And we'll get into this more, but I want you to know how important it is that folks that we're going to work with have never been expected to manage their own bodies, and we're going to touch on that a little bit more. People with disabilities often experience avoidance of care and how it is delivered from professionals. I don't want to see them because, for whatever reason, I got kicked, I got bitten, I got hit. I don't like that, and rightly so. So one of the things that PWP does is help everyone learn that that doesn't have to happen. I do not accept people having to be bitten, hit, or kicked, and neither should you as a PWP professional. You should not accept that. It doesn't have to happen, and we work with that. A lack of service model, there really is a lack of service model to help individuals receive dental, medical, and personal care services with dignity and respect. And I will share with you that one of our huge champions, Leah Rummel, who is a past vice president at United Healthcare, saw Practice Without Pressure as a holistic approach to getting services for everyone. And that's, and I say thank you, Leah. I try to thank everybody and live gratefully. Leah has recognized the value in the approach itself, the whole process, the philosophy in the process, and was directly responsible for bringing us here. She saw that it is truly a service model, and that's real exciting. Perception of non-compliance and what drives non-compliance often does not consider the trauma experienced by both the individual and the caregiver. Now, the key term here is compliance or non-compliance. And I'm going to give you the dictionary definition of compliance, okay? The act of conforming, acquiescing, or yielding. Conforming, acquiescence, or yielding. A tendency to yield readily to others, especially in a weak and subservient way. That is the second definition of compliance. To yield in a weak and subservient way. Conformity, accordance, in compliance with orders. And then the fourth is cooperation or obedience. And the example is compliance with the law is expected of all. Now, I know we don't think about the definition of the word compliance or compliant very often, or non-compliant. But if you think about what I said, conforming, acquiescing, or yielding, yield readily to others, especially in a weak and subservient way. Conformity and compliance with orders and compliance with the law is expected of all. That's how we view how people should interact with their care providers now. Okay, let's unpack that. When you put those expectations out there for people with intellectual disabilities who have very little control over what happens to them anyway, is it any wonder that fights start and people try to flee and hit and do all that stuff? There should be no surprise to that, okay? So that's what drives our health system now, is the compliance of people. I want you to put another word in there. Let's talk about participation instead of compliance. How do you feel when I say participate instead of comply? PWP works to help people participate, not comply. That's scary for providers and for caregivers sometimes, because you have to trust that people are going to do what needs to be done. The trauma that's inflicted when you try to make people comply, yield, acquiesce, is where all the negativity starts and that cycle starts, okay? History of the medical model. Healthcare focuses on the identified disability as the problem that needs to be fixed, okay? Providers focus on differences noted in the individual compared to normative expectations. That's what they've been taught to do, folks. Trauma, fear, and resistance are what occur. Think about the definition of compliance. Unnecessary pressure. What we have to learn, and it's human nature, to, okay, Daisy, I want you to do this. Daisy, can you come on and do this? Daisy, please hurry up and do this. Daisy, I need you to get this done. I was putting pressure on you, wasn't I? Just verbally. Wasn't even doing it with hands, with more people. It was using my voice, my tone of voice, my authority, the position that I have. I'm up here, I'm doing the presentation, so I have a little bit of authority. And I already got her feeling, stop it. You were very gracious, but now imagine if Daisy didn't have a lot of filters on her. I could get her, I bet you right now, to start swinging at me if I tried, okay? Not that I want to try, but it would have happened. So pressure. History shows us that that's how people have been addressed. And what it does is it exacerbates fears and resistance around healthcare services. So what you're starting to see now, folks, is a little bit of a cycle, okay? A little bit of a cycle. I'm an expert on cycles. It's part of my life. A little bit of a cycle. Okay, let's talk about the financial burden. Lack of access to preventative health care increases costs of needed long-term specialized care. Dentally, if people avoid care, who likes to go to the dentist anyway? No offense. I love my new dentist, but who likes to go to the dentist? If you don't like to go and you have an intellectual disability and people force you to go, and then you finally blow up and then nobody brings you, and then let's just say, oh, you develop endocarditis. An infection in your gums that lodges, it goes now systemically, lodges in your heart, the lining of your heart. Oh my, that is expensive. Let me just tell you, Mark was in the hospital for a month on IV antibiotics every 4 hours. He came home and had them for another 3 to 4 weeks. IV antibiotics every 4 hours. I can change an IV in my sleep, okay? So the lack of me taking him to the dentist, and I readily admit all these things, folks, I put myself right out there. We did a lot of things according to the way you're gonna hear about it. We couldn't take him for preventive health care. It was just too hard, So that cost went. He didn't have United Healthcare at the time, so thank God. Okay. There's a difficulty, again, and I can't say this enough, that clinicians and professionals face. They are taught to fix things. They have to make a decision in their minds, how am I going to handle this? Am I going to let it go, or am I going to fix it the only way I know how, with the only skill set that I have, which is either bring in the crew and restrain them, put a papoose board on them, and we'll show you later, or sedate them. So that's what you're working with, folks, okay? PWP works with them too. History of social model, okay? Let's talk about this a little bit. It shifts understanding. A disability is often seen as a disadvantage or restriction of activity caused by a society that is not designed for people with disabilities. If you change to, it's not the person there's anything wrong with. Mark was born genetically with an extra chromosome. That's who he's supposed to be, okay? Society just here doesn't recognize that that's okay. Think about folks that have, they're congenital twins, and I might not be saying this the right way, conjoined twins where only parts of the limbs show. In India, a long time ago, those folks were regarded as gods, okay? Society changed, and now they're not regarded quite so highly. So again, it's the perspective of disability. Society needs to change a little bit more. So the societal model, that's part of what we need to do. We have to shift the focus. Again, we just talked about allowing the individual, or not, and I even hate to, you have to change this in the PowerPoint. Not allow, but empower the individual with disabilities to begin to make decisions, supported decisions, build their skills and capacity, and gain some independence. They can do that. The social model focuses on what someone can do versus what they cannot do. As a parent, I will share with you that from when Mark was diagnosed, which was at birth, he's not going to be able to. The geneticist that we spoke to when he was 2 days old, she looked his dad and me right in the face and she said, he won't be that much different from other kids. But things like he won't know to come in out of the rain. He was 2 days old. That's how she had been taught to tell us. Mark is, and has been since he was little, the first person to go get an umbrella, okay? The first person. We laugh about that every time we hear him or see him do his thing. So what someone can do versus what they can't, that still needs to change a lot. Connect and build trust, folks. While the individual's experiences and the impact of their disability will require a continuum of the level of services needed, the goal is to connect and build trust to move forward in accessing high-quality healthcare services. So hopefully I'm starting to set the stage for y'all that there's a lot of change to be done, but we have the map. We have the map. I'm going to say to you that I think PWP actually goes further than just a social model. I think that we have a holistic model. Again, we work with the whole person, and we work with all the people that affect an individual during trying to access care, okay? The individual, the caregiver, the professional. So it's a holistic model of care. We've talked about restraints. You guys will have to put in your review if you think I'm talking about it too much, but I cannot, in my own mind yet, talk about it too much, about what it does. The healthcare professionals that choose to ensure compliance, they need to understand the noted side effects. And I, believe me, have worked with folks, especially in the dental arena, who treat people with disabilities, IDD, who insist that restraints do no harm, okay? At least admit it to yourself. Understand what you are doing, okay? If restraint is ever used, it should hurt you. Okay, you should really question whether you've done everything that you could. Restraints have trauma and psychological effects. Restraints cause physical injury. They have caused death. People being in restraint have caused death. There's also a secondary trauma. I'm a secondary trauma survivor of all the times I still remember it, laying on Mark, looking my little boy in the face and saying to him, "I'm sorry, Mark, I don't know what else to do." Secondary trauma. And there's trauma to the professionals. I know I spoke with Alan a little bit ago about something he witnessed, and it was brutal for him to witness it. People that are just walking by, out in the MAC, in the lobby, to have to view things, watching that is very traumatic. People that have to be the head holder in the dental world, the head holder. There is such a term and such a position as the head holder in some special needs dental practices. The secondary trauma is significant. Oftentimes you hear about sedation is a chemical restraint. And I agree with that, and this is where I walk a fine line, but I'm not gonna, I don't think it has to be an either or. Sedation can be a way to administer care, and it can be done without trauma. That's what we have to think about. There is danger with sedation as well. There's death, there's expense, there's trauma. But if you really need to get something done, think about sedation as the method. If you don't have the time to spend working out practice without pressure, what you can do is administer sedation without restraint. And you can spend some time right in that moment practicing how to do the sedation. What else I want to share with you guys? First of all, no one learns when they're sedated. They don't learn to participate. But what happens often is sedation becomes the end of the road instead of just a stop on the journey. Sedation should be a rest stop, okay? We should continue to work with people to help them come off of sedation. That can be done with folks that have significant disability, okay? So that's a bit about restraint. Remember I talked about a cycle was starting? Well, that's what we in the PWP world, and supported by Tompkins, calls the negativity cycle. okay? This is pretty important. If you're restrained for a procedure or sedation induction, okay, fight or flight reaction is triggered. You know, you fight, you want to beat up somebody, you try to run away, but people also freeze. And I don't know how many of y'all have seen that, but you know, sometimes you hear people say, well, they wanted it, they just stopped moving. They froze. That is a trauma response, okay? So that negativity cycle is created. When you initially are restrained for a procedure, Dr. Leslie Neely said to me one time, the minute you put your hands on them, you're done. That's when that starts. That trauma response, the negativity cycle starts, okay? We want to fight, fly, or freeze. So continued restraint, fight, flight, or freeze. That's how they continue to get their care done. Parents that feel they have to hold down someone to brush their teeth, every day they're contributing to the cycle, okay? PTS is created, actual PTSD, post-traumatic stress disorder. The individual's perceived as the problem, okay? The individual's perceived as the problem when it's really the approach. They're just doing what their body tells them to do. Get me out of here, get me out of here, get me out of here, okay? This is it in a nutshell. And that's what the whole restraint model does. We're going to move on to the types of restraints. Restraint for sedation, restraint was required to be sedated, okay? A papoose. Papoose is a board. People are strapped in. Posy straps. They're separate. They go on your arms or your legs. Restrained by other people, okay? Others held down the individual on one or more parts of their body. And then restrained or held by the caregiver lays on top of or hugs someone in their lap. This is hard, okay? This is what we're taught to do. This is restraint. If we restrain, we need to deal with the aftermath of that. Now, I don't include this in this course because we're working on not restraining. But what people should do, professionals, caregivers should do, is deal with the traumatic effects of the restraint, some way psychologically, okay? We're here to teach you that you don't have to do that. But if you do, deal with the outcomes, okay? Now, I want you to see the different types of restraints. Over here on this side, you see those are papoose boards, okay? They're made in all sizes, for all sizes of people, okay? It's a little easier to get that little one on the end over there in a papoose board than it is to get that big one on the right. I worked with a man who had 7 adults get him into a papoose board and then shoot him with ketamine, which is a paralyzing agent. And he still had one tear coming down his face, okay? You have to see this. You have to know what it is. The middle, upper middle, while it's a kind of a funny picture, it really is what still happens, okay? Down here, this is a dad, and this is what we did with Mark. Put him on, we were instructed, put him on your lap, flip him over. That is still taught today, and people think that that's what you do, because that's what they've learned, okay? Imagine the secondary trauma, though, from these. That little boy, this is a picture I just got from the internet. We have never been able to make ourselves go out and subject people to this, but this is a picture I got on the internet. You see he's in some sort of clinical setting. He's wrapped up like a shroud, really. So I want you to know, again, what happens. What PWP does is we interrupt that negativity cycle, okay? So we employ the PWP process for procedures or sedation induction. What happens is There's no fight, flight, or freeze reaction. So there's no trauma for the most part. There's no PTSD created or reinforced for anybody, okay? Here's the key. It went from the individual being the problem, or being perceived, not being the problem, being perceived as the problem, to the individual knows they can participate and is perceived in a positive manner. See the difference? We've shifted the paradigm. This happens for medical procedures, dental procedures, or personal care procedures, okay? It opens up that negativity cycle. And when you do it for one procedure, you've built success. Let's say we start with blood draws. The next thing that happens is a dental visit. So now we've got, just like you did it before, you can do it just like you did it before. The caregiver knows, something's changed. The individual knows something's changed. So it's not procedure specific. So it's not diagnosis specific, and it's not procedure specific, okay? So, dental, personal care, and when I say personal care, I mean things like haircuts, because let me tell you, as a mama of somebody who didn't want to get his hair cut when he was little, head holder, kids cuts, head holder, that happens all the time. I can't tell you how many families of people with disabilities cut their children's hair in their sleep. Okay? Because that's what they've learned to do. Nail cutting. That was, quite frankly, Mark's worst thing. Am I right, Rachel? He could, because, okay, I cut his cuticle more than once, his finger. I'm just being honest. He wanted nothing to do with getting his nails done. We had to start over here, emery boards, and then it would be, Mark, take some deep breaths. I mean, that was the hardest thing in the world for him. But now he does his own nails. I can't tell you how many nail clippers that he squirrels away in his bags, but he does his own nails. So he's totally opened. Mark is totally opened with this. Keep this in mind, folks, okay? PWP reduces barriers and increases access. We work with the individual, the caregiver, and professional. The model, and here's where we're going to start introducing some of the actual practice model or process model. We promote the use of building block strategies and techniques through outline sessions to build skills, capacity, and increase independence. Establish positive relationships, building trust, and making connections. It's a shift from the medical model to the social model, what the individual can do, to the actual holistic model of the entire individual and the entire system around the individual, if you think of it that way. We collaborate and work with the entire healthcare team. And again, I want to make sure y'all know, I'm teaching PWP in the purest fashion possible, okay? And I'm going to tell you that it needs to be implemented this way. Is that going to happen all the time? Probably not. But I'm not going to be the one to tell you it's okay. It's okay for it not to be that way, okay? So know what I'm teaching you is pure PWP. But we do collaborate and work with board-certified behavior analysts, with occupational therapists, with physical therapists, with speech-language professionals. We work with dentists. We work with the dental team. We work with the medical team, the phlebotomy team. Okay, so PWP is pretty inclusive. Again, not procedure-specific, not diagnosis-specific. Hopefully you guys are really starting to see that. Stay committed. We're going to talk a little bit more about commitment to the PWP process. That is sometimes harder than you think. And what you're going to start hearing about in the next little bit after lunch is changing, letting go of old ways of doing things. It's a little harder than you think. I'll just put that little seed in your brain, okay? I also want to add non-traditional therapies to this list, like floor time practitioners, Sunrise program, okay? These are programs that work with people with autism. PWP wants to work with everyone, okay? Because again, we are not about splitting up things. We're about bringing together. Okay, 3 main goals long-term. Increase the number of providers with acceptance in treating people with disability, access to better care and health care and dental care and personal care, and increase the quality of life for everyone, the individual, the caregiver, and the professionals that serve them. Because who wants to do this? Wouldn't it be great to have professionals who currently don't want to do this because, oh, hell no, be able to know a little more, feel a little more confident, and be able to say, yeah, I think I could start treating people with disabilities, not just because it's the law, but because I can do it. PWP is simple but complex, okay? Now, this slide, this is my inaugural reveal of the slide. I'm very excited to show this to you all. This is a PWP application of Sylvan Tompkins' affect theory. And I think you had it in your manuals, but this is the first time I've shown this in public. I'm really excited that we have been able to work through the theory and find a way to really explain how PWP works from a theoretical perspective. The affect theory is the innate biological is the key, response to the increasing, decreasing, or persistent intensity of neural firing. Okay, now I'm not a biological scientist, but I think we all know neural firing has to do with the brains and the nerves, right? Biological responses are things that happen, we don't choose them. This is a very basic description of what happens. And it's real important that you know this because this is what happens to all of us, disability or not, when we go about our life. There is a stimulus, be it internal or external. You know, I may see something that scares me, a bird in my house. Okay, I love birds. Excuse me, outside, somebody else, deal with them. Bird gets in my house, I call my daughter at college and say, you have to come home and get this bird out of my house because I'm scared to death. My fear is a biological response. I can't change that. That was the affect triggered. What changes is my life events, okay? I've grown up a little, and I probably wouldn't call her because she wouldn't come from Delaware, but I'm now able to go, okay, there's a bird in my house, there's a way to get this bird out of here, okay? So in my life events, okay, I've changed my response. How PWP works is in the same place, okay? Think of someone with an intellectual disability. They don't have the same number of life events because their life tends to be slower. They have processing delays. Their brains work slower. It's a way to think about it. It's where the term retardation comes in. Something is retarded, it's slower. Yeah, it's hard for me to even say that word now, isn't it funny? But the term retard or retarded means slow. Think of a flame retardant. What it does is it slows down the flame, okay? So people with disabilities learn with IDD. I'm gonna use the term IDD from now. Is everybody okay with me using IDD? You know what I mean? Okay. They're slower. Their brains are slower. They have less life events, right? Takes them a little longer. I always say if Mark lived to be about 400, he would be driving a race car. He just learns slower and maybe a little differently. Practice without pressure intervention helps to, I have started to think of it as I lend my life experiences to Mark while he's going through the stimulus affect piece. Sandy, I see you have a queryful look on your face, like, what does that mean? So let's say Mark saw, or Sheree, I'm going to use you. Sheree, you saw a needle and you went, Daisy is your practice specialist. Daisy is right there with you to say, look at me, follow me, let's take some deep breaths. Daisy is using her experience and her skills to help Sheree right here, okay? Before Sheree jumps up and runs out of the room. If you apply restraint instead of working with someone, they're not learning anything other than to be afraid, okay? If you apply an intervention over here and try to change the response without understanding what's going on here, it takes a lot longer. The result, the affect results in a feeling. It results in a facial and body display and skin changes. Me sweating, okay? Affects feel rewarding, punishing, or neutral. Affects make things urgent. Me seeing that bird in my house, gotta get it out of here, okay? Cherie seeing that needle, I gotta get up and run. It's biological. It's not, I choose to be non-compliant and get up and run out. I want to start changing your mindsets on that. Awareness of an affect is a feeling. I'm afraid. I'm afraid I don't like birds. I'm afraid I don't like needles, okay? We don't know what people are thinking. That is a true statement. We can only know what they're thinking if they choose to tell us, or we can judge from how they respond. Often out of awareness, we develop rules to try and get more positive and less negative effect. Sylvan Tompkins calls these scripts. How many people, when they go home, throw their shoes off? Or sit down and go, after a long day? Those are scripts. You do that probably every day. Oh, thank God, it feels so good. That is an enjoyment script. It's brought about by your biological responses all day, okay? The pattern of scripts a person uses, whether you are aware of them or not over your lifetime, makes up your personality. This is like looking at a molecule in the Tompkins theory, but it's the easiest way for me to explain it. You don't need to worry about personality and all that stuff. I just wanted you to have the background and to understand where PWP fits in as an intervention, okay? That is the ultimate. We want to get that intervention between the affect and the response, okay? So my Mark, when he sees me, when he used to see me coming towards him with a nail clipper, so what I did was I intervened before he could pull his hand away. Okay, bud, I'm gonna put it down here. Then I'm gonna move up here, then I'm gonna move up here. Kept the energy low. I was able to intervene right there before his previous response kicked in. When you see people that are running as soon as they see something, that script that they've developed has become so strong that it's going to take a lot to intervene in that, to change it. Recognizing previous trauma, exposure to abuse and violence, and honestly, folks, even seeing it on TV does cause that trauma event. When trauma occurs, it might be more difficult to engage the individual and their caregiver. Over time, they may avoid health care. Again, we've talked about this. some experiences that could potentially increase trauma responses for an individual or a caregiver. Let me ask you a question. Do you think the reason behind why someone is being restrained matters? And I say that because if someone's being restrained for to get a vaccine, that's good for them. Okay, and they're restrained. Do you think it matters to them that they're being restrained for something good to come out of it? No. Okay. If they're being restrained for dentistry because they have a huge tooth abscess, does it matter to them in the moment? And think back to the stimulus and the affect and then the response. There's nothing cognitive about that. So it really doesn't matter. And it's, we have to help the providers who think that it's okay to do restraint, that it doesn't matter. It does matter, okay? The biological responses happen. It doesn't matter to your body. If I came over to you right now, Alan, and put my hands on you and refused to let you get up, I could have you swinging in a few minutes, I think. Seriously, I could have you swinging. Doesn't matter if you have a disability or not. If I'm strong enough to hold you down, my reason for, I'm using you as a guinea pig in class. You know my intentions are benign. But it won't matter to his body because his body knows he's being restricted, he has no freedom to do anything, okay? So, if I came over to you and said to you, Alan, I'm going to put my hands on you and not let you get up for 5 minutes, that would help, right? Because I'm setting some expectations and I'm communicating with him what I'm doing. I'm not saying to you, you're okay, it doesn't matter, you're okay. Alan, you're going to be restricted of movement for a few minutes. Because Alan can understand that, right? So the communication, he won't have because I'm communicating, I'm doing some connecting and I'm doing some different approach, he won't have the same amount of trauma, okay? That's what PWP approach does. I want to go to cultural responsiveness. That's real key no matter where you are. And I want to say, you should know the individual and their support system, whether that be the culture. Think about culture as, it's not just societal culture, but it's culture within an individual's own home or where they live, whatever that may be, okay? Some culture difference are noted in research around procedures. Things go from, Johnny's dad doesn't believe in autism. He doesn't believe there is such a thing as autism. Or Isaiah's mom believes that autism is a disease that can be cured by prayer. Those are cultural things. You have to be aware of that. Okay, just keep aware of that. You might have culturally a father does not interact with the family, or might have the final say in whether the individual can actually come for services. Okay, there might be societal differences. You just need to be cognizant of those things where you are, and know that there's differences. Okay. A friend of mine she does work, but she is Native Hawaiian. She is a PhD in nursing, the first Native Hawaiian who ever had a PhD in nursing, by the way, and I'm very proud of her. She has created a culturally appropriate direct support professional curriculum. And it's really interesting to see how she wove in the Hawaiian culture of a lot of plants and herbs and things like that into her curriculum. Here in San Antonio, the Hispanic culture is very strong, so we want to make sure that we bring in that we might go someplace else and the African culture is very strong. So just be aware of what you can bring in culturally responsive. Let's talk a little bit about setting expectations. This is a key part of practice without pressure. Communicating what is desired. Sometimes that's something so simple we don't even think about it. If that had been done for Johnny or Gina before their dental appointment in a calm manner, let's make sure that we all understand it's not, I'm taking you to the doctor right now. That's not setting an expectation. Well, it is, but it's setting an expectation of, and you better be good. We need to set expectations in a calm, engaged way. You know, Daisy, I love you dearly. I would prefer that you not look at your phone when we're here. That's setting an expectation for Daisy. You know, Cherie, I know that you're very interested. Can you make sure that you write down all your questions? That's setting an expectation, hopefully being respectful. You want to be respectful, but you want to set expectations for everyone. So setting expectations it's key. It's allowing us to have a goal, helping us to be on the same page. Caregivers and healthcare providers, it's critical to shift the negative expectations to positive. That's huge. And you'll see more how to do this. I want to note here that expectations of individuals with disabilities are historically very, very low. Very, very low. Part of that goes with they're not expected to manage their own bodies at all. And then what happens from that is if they can't manage their own bodies, then they can't have a say about what happens to their own bodies. Think about that. That's the expectation. I've seen situations where individuals start getting very upset about things being done to them. But then you start getting the history a little bit and you find, back up, rewind. That individuals start doing things to other people, okay? Going up and hitting Sandy because she's within arm space. Then you find out that their boundaries have never been respected, okay? So we want to be able to set expectations that they can manage their own bodies. And some of these things are going to take time. I want to make sure you all understand that words matter. I mean, we do understand that. Our discussion about retard and retarded earlier, okay? It is just a word, but the meaning behind it has grown to be awful when it's said out in the world. Categories of disabilities, okay? As the world currently categorizes them. They do not describe people, they describe conditions. People with disabilities are still viewed as their condition. The key to changing that view is to start thinking of them and referring to them as people with, not as, he's a Down syndrome person, okay? Or she's cognitive, she's low functioning, she's a cognitive age 3. Okay. Becky, what's your cognitive age? Sandy, what's your cognitive age? 182. But now we're laughing about that, but Mark, we're here, I don't think you ever hear me say the words low functioning and high functioning. I want us to understand words matter. The DSM, it's called the Diagnostic and Statistical Manual of, are you ready for this? Mental disorders. This is current language, guys, current language. But it's the handbook used by healthcare professionals in the United States and much of the world as the authoritative guide to the diagnosis of disability and mental disorders. So we're going to go through DSM-5 diagnoses. I want to tell you that, interestingly, Down syndrome in and of itself is not listed in this diagnostic and statistical manual because it's able to be diagnosed genetically. if it's Down syndrome with intellectual impairment, then it can be listed in the DSM-5. I don't understand why. I can't tell you why right now. I may have to find that out over time, but that's how they have used that. And this manual is used everywhere.